Hello, everyone. I hope you aren't in too much of a food coma yet. So I am the last speaker of the day, which really gives us a lot of flexibility. Do I need? Oh, I still got to go there. Sorry. Okay. And so I'm cool of people just asking questions as we go along. We don't have to wait till the end and have that whole official Q&A session. So if something comes up, just speak out, yell out, whatever. We are going to be going through depression, just kind of what is it? We use the terminology all the time, but what's it actually look like in a practical way? We're also going to talk through then what are some treatment options, what can families do, and we'll go from there then, okay? So just kind of an overview of Down syndrome and mental health. So research is somewhere in the ballpark, 1 in 4, 1 in 5 individuals with Down syndrome also display mental health concerns, psychopathology, with dementia or Alzheimer's, obsessive compulsive disorder, OCD, and depression being the 3 most common types that are also comorbid or in addition to Down syndrome. Rates, always in research, there's a lot of variability within just the depression and Down syndrome population, up to about 11%, which usually aren't that different from the general population. But then when we compare the Down syndrome population to just the individuals with intellectual disabilities, it is significantly higher though compared to their rates, which are around 1 to 3.5-ish%. So some of those risk factors, so significant life events. This could be a sibling moving out of the house or leaving for college. This could be transitioning from high school or aging out when they turn 21. It could be a family move, loss of a loved one or a primary caregiver, changes in the school setting. So things that we might just see of, oh, these are all normal life events, but there's still significant life transitions and can be very impactful for any individual, really. Social isolation. So today we're really going to talk about kind of that transition phase of, okay, they've been in school all their life, now what's adulthood look like? How do I make that change? How do I get them the supports they need? How do I help them, figure out that mix of what's the most advantageous schedule for them? How much structure do they need? Things like that. Just advancing age, lower functioning activities of daily living. So just going along with that age piece of differences in cognitive functioning, behavioral functioning, if there's any medical or underlying illnesses that are also contributing just to their overall functioning levels. And then there's also a higher prevalence rate among women, just as there is in the general population. Also with individuals with DS, there are structural brain changes in terms of brain volume. So the hippocampus is involved in things like memory and tied to the limbic system, that fight or flight response, long-term memory and learning. And so by nature of those structural changes, that also increases that risk for depression as well in the Down syndrome population. So what is depression? We use the word all the time. It's a very mainstream terminology. When you hear the word, what do you think of? Sadness, okay, probably the most common one, the hallmark of it. Okay, so not really a desire or an interest to leave the home or do whatever those activities are. Okay. Loneliness. What was that? Hopelessness. Exactly, yeah. A change in preferences, things that you once found pleasurable are no longer so. Anything else? Lack of motivation. Mm-hmm. Turning inward. Okay. Oh, anger, excuse me. Anger. Emptiness. Okay. Well, I think you guys hit on a lot of these. Sadness, yeah, the hallmark of it. The hopelessness. Someone mentioned the loss of interest. Also, some more of those physical symptoms, significant changes in weight, being losing weight or gaining weight. Difficulties with sleep, so difficulties either initiating sleep, maintaining sleep throughout the night. Psychomotor agitation, so a lot of pacing, restlessness, leg tapping, things like that. Fatigue, loss of energy, kind of that lower level of energy, feelings of worthlessness or guilt, and then inattention and some of those cognitive changes. So these are just kind of the standard depression symptoms. And these are two of the main kinds. So we have major depressive disorder, which is 5 or more of those symptoms during the same 2-week period that represents a change from previous functioning. So that's really a key there. Another is that the symptoms cause clinically significant distress or impairment. And so the second one, the persistent depressive disorder, this is kind of like more that lower grade fever. So this is at least 2 years, but less symptomology. So this is kind of that more pervasive, lesser ongoing state. So what's this look like in terms of the Down syndrome population? So children and adolescents often display more externalizing behaviors. So aggression and attention, but then as they get older, it often moves to those more internalizing symptoms. So depression, loneliness, things like that. Oftentimes, too, they present as more biological versus cognitive. So cognitive features of depression in the general population are like disturbances in memory, loss of concentration, suicidal ideation, whereas the biological components are more like the psychomotor retardation, disturbed sleep, loss of appetite, loss of weight, fatigue, more of those behavioral physical expressions. It may also might see a decline in adaptive skills. So their self-care skills, their feeding skills, their hygiene skills, things like that. And always we want to make sure to rule out any underlying medical causes. So things like thyroid concerns, vitamin deficiencies, sleep issues, just to make sure there's not something we're missing that could be attributed to the behavioral expression that we're seeing. So how do we actually go about diagnosing this? So oftentimes the clinical interview is really the main piece. So we get the report from the caregivers, the parents, as well as the individual themselves. This could be with your family care doctor, primary care physician, psychologist, psychiatrist, mental health specialist. We'll assess for history, so looking for that change in functioning. We'll get a thorough medical background too to make sure, if we need to refer out a psychologist to an MD, that we address those, and then really that behavioral component as well. Might also include some standardized forms, some different checklists, both for the parent or caregiver as well as the individual. So if you're seeing these things, how can you help? So the first piece of this is recognizing the impact of transitions. So maybe you've got multiple kiddos and others have adjusted well to the move or adjusted well to a sibling leaving, but realizing, hey, this is a different kiddo, maybe their response is going to be amplified or maybe even it's delayed. So it might not be within the first week or month after that sibling leaves for college or after there's been a family move, but it might be 6 months down the road when it's more set in. So it might not be an immediate change. So if you're starting to see these behaviors, you're like, where did these come from? These are out of the blue. Thinking back, okay, is this a delayed response to something else? Maybe there wasn't something in the last month, but has there been something in the last 6 months? And now we're just kind of seeing those significant behavioral changes at this point. Look at those relationships. Caregivers, teachers, staff, all those things are changing. If they're used to being in a school setting Monday through Friday, seeing the same faces day after day, aging out of the school system and going into a work environment, a volunteer environment, whatever that looks like, those are all going to be significant changes. So not underestimating that impact as well. And then also just their daily schedules, routines, activities, all of that is in flux. And I know I even talked to some parents just this morning about, okay, they're out of the school system. How do we find those daily supports? How do I structure their day? What supports are even out there? So knowing too that this, as we've talked, depression isn't just a sadness piece. It could be anger, it could be irritability, it could be fear, or they're scared, they're frightened due to that loss of predictability that they've had in their life. So first step is just being accepting of those feelings and validating their experience for them. So start early. Some life events, yes, they're unexpected. You can't plan for them. They come out of the blue. Other things like that transition out of the school system, you know it's coming. So as early as you can, start planning, start talking about it with your child too. I know one thing, Phil Clark with Enable Special Needs, hopefully you all spoke to him today. One of the biggest things that they learned from his sister who has Down syndrome is they sometimes forgot to include her in the conversation, and how much his family now has learned looking back. And so often as adults, we get going and we're like, okay, we got to do X, Y, and Z. Here's our to-do list. We need to contact these people. We need to file for these waivers. And we forget to actually include the individual themselves and get their input and start prepping them for those changes ahead, because we just kind of get in that go to do mode and are just, we have that tunnel vision. So make sure you're including them in all those conversations as well. Talk about the daily changes, the new people, what their routines will look like. If you can tour any settings in advance, even multiple times if needed, you all know your children. You are the best expert on them. You know how they're going to respond to new situations. You know if they're kind of go with the flow and one time they're going to be fine. Others, might need a half dozen times to get them comfortable and functioning well in that environment. The next one is establishing new routines. So they're used to structured routines oftentimes in the school. They have wake-up times, they have bus schedules, they have caregiver schedules. But now, even if part of their time at home is structured, maybe they have certain days they volunteer or go to a place of employment, and it might seem like, okay, they've got a couple other days they can just chill or relax and not all their time has to be structured. But once again, you know how your child's going to respond to that. So some kids might be okay with that. Others, no, they need way more structure. They need even hourly. I've worked with some individuals who just thrive on knowing what that routine is. Even if it's all things around the house of there's chores or there's TV time or there's board game time or there's Skype time with family, they need that much structure and predictability within their routines. And so that leads into the second one of creating those small routines. So sometimes, you don't have to go home and figure out every minute of every day, but looking at their schedules, if you're like, they just kind of feel like they're floundering or they don't seem as happy, where within their day, within what you're already doing, within your environmental restrictions, can you just create small routines to create that predictability, that comfort, that structure piece to it? Next, be conscious of those relationships. I mean, especially when they're in a school environment, they're around peers, staff, kids, adults, and if they're transitioning to the home environment, even if they're only, home with a caregiver 2 or 3 days a week, that can still feel very isolating. That's still a significant change from the environment they were used to. And so not underestimating the impact of no longer having contact with those individuals. So technology is great in this setting. If there's logistics, transportation issues, even something as simple as setting up like a structured weekly, like maybe Monday mornings at 10 o'clock, they Skype with, one of their best friends from the school setting. So they have like that online date time if they can't be seen in person, but giving them that peer connection on a regular basis. Are there any extracurricular activities? Joseph Maley was also downstairs. They have wonderful recreational programs if you aren't familiar with them. Help them find purpose. This is such a key. So before they were a student, that was often a big piece of their identity. Their job was to go to school. Now all of that's in flux and it's gone. So what's that going to look like now? How are they going to feel like they have purpose? How are they contributing to the family? How are they contributing to their relationships, their neighbors, the community around them, all of those areas? So are there organizations they can volunteer with? Are there employment opportunities? How can they contribute just to their immediate household needs? The next one is being aware of that stress piece. So both first identifying the stress and then how can we reduce it? So part of that starts with just the biological components. Are they getting sufficient sleep? So is it taking them hours to fall asleep? Or are they restless at night? Because for any of us, if we aren't getting good sleep, those behaviors go up. We get way more irritable. We are cranky with others. So looking at the practical nature of things like that first. Are they getting an adequate diet? Is it now they used to be on a pretty structured meal schedule. They were at school for some meals and now they're home and they're kind of left on their own, or they can get their own things. And so it's the snack foods, things that don't have a ton of nutritional value, because even something as simple as that, if that's a significant change in their diet, can increase that irritability. If they're having mood swings or there's certain times of day you can identify when they're more irritable. And then having some more movement. So just not screen time 8 hours a day, getting outside the house, walking, the simplest things. Whatever works within their environment, whatever's available to you all. How can we get them engaged in preferred activities and hobbies? Is it with a neighbor? Is it with some structured formal program? Is it a caregiver just making that intentional time 15 minutes a day or weekly to get them out doing what they love, or to give them access to whatever that preferred activities? Or what changes can we make within their environment to provide that accessibility? Things like that. I had one family and their son loved trains. Trains was his thing. And so they just happened to have, they lived somewhere in northern Indiana, and there was like a model train that sat out. And so every day his routine, because he had aged out of school, became they just walked and they looked at this model train. It was like a 20-minute thing, but they started his day like that. The walk was at 9 a.m. and that was like a game changer for them, because he started his day off in a super happy mood. They got him outside. If the weather was too bad, they would drive, look at the train, sit for a few minutes, and then go home. And so these don't have to be like these huge plans. What is an interest to your child? What is a little practical thing in their day that could potentially have a really big difference? So when you feel like you've exhausted all those options, you've racked your brain, you've talked to others, you're like, I've made all the environmental changes that I can, I don't know what else to do, then maybe it's time to consider getting some professional input then. So the most common are treatment or medication. So treatment, therapy, counseling, it's not a cookie cutter, one size fits all approach. It could be brief, 3 to 4 sessions, or it could be long-term, ongoing weekly, or maybe it's just a monthly check-in, just depending on the functioning level of the individual we're working with. Or it could be just based on the individual and their needs. We're like, yeah, we probably aren't going to get too far in that. So maybe we need to consider medication, kind of off the base, kind of enough to take off the edge, to help them be less irritable or angry, to help them start functioning better. And maybe that needs to be our first line. And then we'll do some treatment to help get a game plan then to help them sustain that or reassess those environmental factors, that type of thing. So I always say consult with your primary care physician, your family care doc. Usually most are comfortable prescribing something like anti-anxiety, an SSRI, something to that effect. But then I was talking with some families too, and they were just trying to get some anxiety meds for their daughter, I think it was, and family care doc was like, no way, not prescribing it. So sometimes you do get that, but usually I always tell my families, start with your family care doc, because if we're just talking a low dose of anxiety or antidepressant, I don't think we have to go seek out a psychiatrist right away. And that's kind of like finding a needle in a haystack often too. So let's start with what's accessible to us. So going along with that treatment piece, hopefully many of your sons or daughters have the waiver supports. Life Choice does in-home behavioral and mental health services. So it could be too, once again, you're like, no, my child just needs to get out of the house. So it'd be best to just come to you, come to your office. That'd be a good weekly routine for them. Others are like, no, we need someone in our home environment because behaviors are really becoming pretty significant. And so we need someone in the midst of the environment to help us get a behavior plan in place to think through these things. And so Life Choice does in-home. They're in a pretty broad central Indiana area. Collaborative Change is another one I work with. Their offices are located near Meridian and like 96, but they also do in-home as well. So if you're looking for the in-home, those first two are great resources. And then the Family Service Society, a couple of those therapists I specifically listed have a lot of experience working with the Down syndrome population as well, because I know we have some families from Richmond and other areas of the state. So as well as myself, my office is in Fortville. So I do the diagnostic evaluation side. So often when there's a comorbid in addition to Down syndrome, so be it autism, ADHD, mood difficulties, behavioral issues, but then also the ongoing treatment and counselors, both for those individuals as well as caregivers, because clearly you all need the supports too, and your own outlets and avenues as well there. So that's all I have. That's kind of a quick overview. What questions, concerns do you all have? Because you all are living this, so yes.
I wanted to say one of the things that I do with my son, he's 32 this month with Down syndrome. I do calendars, whiteboards. I have a large whiteboard that we do the calendar for about 2 months at a time. And that way he can look on there and see what's coming up, what he, and, his appointments, his fun things, his friends coming over, all of that is there. And then each night we do a very small whiteboard for the next day before he goes to bed, so he knows exactly what will happen the next day if I need to be out, or because we live in an apartment together, and he calls his portion his apartment. He takes ownership of it, and he loves the arrangement because he has so much independence.
Okay.
But that has been a major stepping stone for us, and I've done it for years, and he will not let the board be inaccurate. If anything changes, he's right there. If that helps anybody.
I love that practical tip. And so if anyone couldn't hear, she was talking about 2 months at a time, they do large calendar whiteboards. So her son can see exactly what's coming, what events are there, what the schedule's going to be. And then he also has a smaller whiteboard that he uses for the next day. And so that's a way to increase that structure, predictability, that routine. And it sounds like it's working out great for him. And he's been very responsive to that. Wonderful. Thank you for sharing. Any other tips that parents, as you found? Yeah. Okay. Thank you for sharing. So he mentioned the Down syndrome clinic at St. Vincent with Dr. Escobar. One of the clinics I've been in, Dr. Escobar is one of my main referral bases. So I am very familiar with him and his work. And yeah, he is wonderful of working with families and figuring out what their needs are and referring out if he needs a psych or testing or ongoing treatment as well. Thank you. I think he's correct me if I'm wrong, because I'm primarily children and adolescents in my practice, but I think birth to adults, is that? Okay, they're at 19. Did someone else say no adults? Okay, so sounds like children and adolescents, maybe up to that 21-ish, 18 age. Yes.
We've had trouble finding actual psychiatric care for our nonverbal kiddo. And so he's been managed with a primary care physician in terms of medication and that kind of thing. He's starting as he's getting towards his adult years to have some new psychiatric problems.
Mm-hmm.
And we're kind of at a loss as he's aged into an adult. He's an adult, and yet he's still developmentally delayed. He's still nonverbal.
Mm-hmm.
And just finding any kind of scenario that can adequately support his mental health needs. Do you have any idea?
So by psychiatric concerns, do you mean medication management? Do you mean behaviors are getting more challenging? Like, what is your definition of psychiatric concerns?
Medication management, figuring out if the medication he's been on for the last several years
Okay.
is appropriate, or if there's something else we need to try, or a different dosage we need to try, that kind of thing.
Okay.
And his primary care physician is maybe where we need to stay, willing to
Okay.
tinker with it, but he's honestly saying it's not my area of expertise.
Okay.
I'm willing to help you if you can't find somebody else. And that's where we're at right now. We can't find somebody else.
Okay.
I have that same issue just because my daughter is essentially nonverbal. Just finding anyone that's willing to try to figure out what's going on.
Okay.
And I'm in the Evansville area, so I'm not even.
Okay.
So it seems like I had a family doctor refer me to psychology psychiatrist group,
Mm-hmm.
and when they talk to me, we don't handle that. We don't know how to do it, and no one can tell me where to go beyond that. My next step is the CYACC
Mm-hmm.
to start with, and then let my doctor supplement that. But it's even finding someone for counseling, especially when you have a family member that's essentially nonverbal.
Mm-hmm.
So we have the same problem with job coaching. They don't know how to interact with them. And frankly, there are times I don't know how to do it.
So there's.
Real struggle.
I'll be honest, even if communication wasn't a problem, it's nearly impossible to find mental health treatment for somebody with developmental disability in many states.
No, by all means, please. So there's a lot of concerns I'm hearing. Yes. So this mother had brought up, it sounds like an adult psychiatrist, which I'll be honest, most of my work is children and adolescents. And so I am not well versed in the adult psychiatry options around the Indianapolis area. And then it sounds like with both of these parents getting behavioral supports, because I think both of you said your sons or daughters are nonverbal. Okay.
Not really behavioral. It's psychiatric and mental health services is kind of an unmet need in terms of psychiatry, even for kids and adolescents, but especially for adults. And what Charlie, the doctor said is that's regardless of whether your child's verbal or not, it's just really hard right now to find any kind of mental health services. So we all just have to sort of piece together the services that we can and do the best we can and know that it's not enough, but there's no other option.
Anyone have any adult psychiatry referrals in Indy? Dr. Ciccarelli, do you have any insight for that? I'll just put you on the spot.
Midtown the only place that has a formal dual diagnosis program is Midtown Community Mental Health, and they do, and that's called the STAR program.
Okay.
So you can't go just with intellectual disabilities, you have to go with a mental
Is that Sagamore in West Lafayette? The Sagamore
No, there's another one.
Wabash Valley?
Wabash Valley, Fort County, which is in the middle of the state, has some services. So it's spot.
Bellman Center up in northeast.
Bowen Center, yes. Actually, that's who I was thinking of. Are some that have done a better job with trying to develop their services.
There was a request for a list of everything that was just said. So there's Four Quarters Counseling, which is in Bowen, and Cummins, Midtown's here in Indy, their STAR program. Oh, Midtown Star, excuse me.
And Meridian.
Meridian.
Is there something you could Google that under?
No. Not that I know of.
Nobody in the south or southwest area.
I have to go back and look. I don't hold all this file in my head.
We understand.
Thank you for sharing that knowledge you do have in your head, though. Yes. Okay. Okay. So she was just saying, just in the last month, she's contacted Dr. Escobar's office, seeking referrals for a primary care doc for adults. And Dr. Escobar really didn't have anywhere to send her or any recommendations or suggestions.
In what part of the state?
He's here in Indy.
So I usually recommend folks who are double boarded in internal medicine and pediatrics because they have more experience with syndromic conditions of childhood but care for adults as well. In the St. Vincent system, Lisa Altuglu is a med doc. There's about 200 med docs in the state. You can do that.
But what if they're older than a pediatric?
No, med docs are what I am, internal medicine boarded and pediatric boarded, and they take care of people from birth through death. She's the only one I know in the St. V system if you want to see that. Lisa Altuglu, Altuglu. But there's people scattered across the whole state.
So I think going back then to kind of the behavior piece initially of both of that questions of how do we get those behavioral supports, I'd say having an in-home behavior therapist, one of the agencies that takes waiver supports, like Choice. What?
That's not that hard to find.
Okay.
Adult behavior specialists. There's some downstairs.
But they have mental health counselors as well. So when I say behavior, usually it's the behaviors or expression, like we just all talked about, of the depression, the anxiety, of the underlying mood disorder often gets expressed in behavior, especially in the nonverbal population. It's the observation of those behaviors that you're seeing from an underlying mood component. So I'm using behavior in a very general term to encompass that mood piece though too. And a lot of these community resources also have mental health therapists on staff and take the waiver and give waiver supports. And so reaching out to some of those from that realm versus trying to go to, a private practice clinic or somewhere like that and just directly trying to get mental health supports for someone who's nonverbal, your better option is probably going to be going to some of those community, but saying, hey, do you have a mental health therapist on staff to do some in-home waiver supports and going at it from that realm. And then as Dr. Ciccarelli had mentioned, with Midtown Star program, you've got to have that first level of anxiety, depression, whatnot. And so getting your primary care doc, hopefully, to get on board and making that as the primary diagnosis then, so you can access that. Is it Any mental health
Any DSM-5
Okay.
diagnosis, but if you say you're just coming with autism or just coming with intellectual disability, they won't see you. So you need a label. You need
Okay.
an adult DSM-5 label, not a pediatric DSM-5. So if you just
Okay.
come with disruptive behaviors, that's not a diagnosis, that's a symptom. And
Okay.
so that's an interesting problem when people are moving from pediatric to adult care from a mental health perspective, is that the cache of diagnoses used in childhood are different than the cache that are used in adulthood. So, we don't label people as personality disordered in childhood on purpose, but you need that diagnosis to get the adult services. So it's an interesting problem in transition of having to make that flip into the new vernacular. They both describe the same things, it's just different language used.
So that's something, if your family care doc is not comfortable with, a psychologist like myself could go through the evaluation, which would, going back to the beginning, be just like that clinical interview, maybe some self-reports, parent reports, and get that diagnosis, anxiety, depression, OCD, mood-related disorder, to then access services such as the Midtown Star.
So I don't see if, is Rich gone? Because, his advice this morning was sometimes just that lie. Since depression and anxiety are too much close common, I'll just put one of those two. I know it's a mental health disorder. I'm not a psychiatrist. It's not my job to know which mental health disorder it is.
Mm-hmm.
But the odds are it's one of those two, so I put that. You could be so crass as to encourage your primary care doc to do that.
And we just talked through all the depressing symptoms. I mean, look over that list. Many of you, just talking with you casually this morning, went down the criteria enough, to just like informally make a diagnosis. So if you are going to your family care doc with this intention, Google it, literally depressive symptoms, anxiety symptoms, OCD. We've even talked about the non-traditional of irritability, those behavioral changes. And so walk into that office and say, here's my list. Yeah, maybe I don't know exactly which one this meets, but surely this is enough to get some mental health diagnosis in for me. And so really kind of help them out and clearly document all of those symptoms, behavior, mood changes, changes in functioning, sleep issues, physical changes, biological changes, all of those, and take that to your doc then that way. What other questions, concerns, helpful info you have to share with others? Anybody? I kept my part pretty short and sweet because, I was expecting lots of conversation here.
Well, it's hard to have that conversation when you're still trying to figure it out.
Mm-hmm.
So you're giving us information, giving us food for thought is good. I don't know that I have questions now, but it doesn't mean I won't as I go through this and put it together.
Well, my contact information is on the slides. If yes, you drive away and with your drive home to Evansville, you come up with 10 questions, please just email me. Even if you're out of the area, I'm happy to chat with you by phone or email and just try and help you brainstorm, or you're like, okay, this is the issue. I don't know quite what to call it. I don't know what resource to ask for it, be it a mental health therapist, a behavior therapist, if I can get in-home supports with this, if my only option is an outside clinic or a private practice, I'm more than happy to try and help negotiate or reach out to other professionals in the field to see if we can brainstorm or get you connected, whatever that looks like.